Hey everybody, hope everybody's well. I just messed around with my microphone, so let me know if you can, I want to make sure that you can hear me. So give me a little message. All right, cool. Thanks, Sean. Awesome. All right, today what we're going to talk about, oh, by the way, welcome to BFR Tuesday, where every Tuesday we do some sort of webinar on BFR training, research, guest lecturers, whatever. It's all about BFR. I'll spend the next 20 or so minutes talking. Today I'm going to talk about the electric stim unit that I use now. It's kind of a relatively new unit, and I've searched all over the place trying to find a decent unit, and I'm really happy with what I got. So I'll show you what that's all about and when to use it. So I am going to, I'm going to do a screen share and share that entire screen. All right, cool. All right. All right, so what I like to say is this is BFR training, evidence-based approach. Everything that I do is based on not only the scientific literature, but also using BFR training every day with my patients that it's appropriate with, and also in training of my own. So if you're new and not sure who I am, I'm Ed Cara. I practice out of Dallas, Texas. And I really became interested in BFR training a couple of years ago, almost 3 years ago now, because in my mind, using TheraBand and resistance bands and these little things, light weights, I knew I wasn't creating strength and hypertrophy. And so instead my mind went to, okay, well, how do I justify giving people exercises? And really before BFR, I just thought, well, I'm giving people some motor unit recruitment. I'm trying to improve motor control, corrective exercise strategies, because I knew I didn't have enough time to cause true strength and hypertrophy. I don't have 12 weeks with most patients. I'm an all cash-based practice. I typically have a couple of visits to get people out of pain, maybe a couple more visits in order to improve their strength and stability. But realistically, I just don't have that. I don't have enough time or enough visits to truly cause strength and hypertrophy. So when I got into BFR and the research, seeing that I could get changes in 2 weeks and cause true strength and hypertrophy at very low loads, I've been geeking out for forever on this stuff now. So that's it. I just want to share with you what I'm doing and why I think it's so cool. And how it's really helping me with my patients, but it's also helping me just as a provider to give me a better sense of worth, to be honest, how I feel like using BFR helps me get people to places that I need them to go versus me just doing manual therapy. And I don't want to say just in a negative place. I think manual therapy is a vehicle to get people to do more exercise as a pain controller, motor control changer. But it's really just a bridge, and it's my personal opinion that you have to stress and load tissue, otherwise people can't get back to normal activities, especially our high level and even medium level athletes. So you can look and see if you have any questions at all about anything that I have or I covered today, ed@edlacara.com is the best email address to get me, or you can catch me on my Instagram, which is Body Lounge Park Cities. That's my clinic Instagram. Or at Twitter, @Dr. LaCara. Okay, so I've been using BFR for the last almost 3 years now, and I use it every day with my clinic, in a bunch of different ways. I'm gonna share one of those ways with you today. What is blood flow restriction training? It is the brief and intermittent occlusion of arterial and venous blood flow using a tourniquet while at rest or exercising. Using this technique, you can exercise using significantly less weight and still achieve significant gains in muscle strength and size. You're able to do things that we couldn't do with just light TheraBands and light loads in a very short period of time, like as little as 2 weeks. So if we look at the BFR continuum timeline, I kind of look at this line as, well, what column am I going to shove people into when I think about training with BFR or even without BFR? What can I do for patients pre-surgically? Like, you know, what's the main goal of somebody? Preparing them for the surgery, prehabbing them, trying to get them to prepare it as well as they can for the surgery so that their rehab is not as long afterwards. Then once they have the surgery or they have their injury, what am I trying to do? I am trying to get them to heal as fast as possible. I'm trying to get them back to their normal activities as quick as they can. And that might take some time. That might take 0, maybe 8 weeks. Maybe they return to play at 9 or 10 weeks. And then after all that, then they can get into performance. So BFR can play a role in anyone, anytime along the continuum, as long as they don't have any contraindications. So in the first phase, pre-surgically, we're trying to reduce atrophy. We're trying to maintain muscle strength in other areas outside of the injured area. Typically, that injured area, we're not going to be able to get strength and hypertrophy. Hopefully, we're able to maintain. During surgery or injury, we try to improve aerobic capacity and maintain muscle mass and strength. Once we get close to returning to play, we want to increase size and strength, and then we want to maintain size and strength and help with recovery during the performance stages. So if you look at you kind of look at this, we look at it as, hey, the person is non-mobile, non-weight bearing. This could be in the pre-surgical or in the right after the surgery, right after the injury. Here's where we're going to be talking about our cellular swelling sequence or protocol. And that's what we're going to be talking about today is when we use electric stimulation with our cellular swelling protocol, what kind of stim units do we need to look for and can possibly purchase? And then they go to aerobic or weight bearing, then isolated exercises, then compound exercises, and then they get into performance. So what we're going to focus on today is this right here, this pre-surgical and immediately post-surgical or post-injury. You don't always have to start in that non-weight bearing. If the person is mobile, you can get them right into mobile exercises. You can get them right into isolated exercises. You can get them right into compound exercises. But if they're not mobile, and you'll see the algorithm as I pop this up, we would start them in this pre-surgical or surgical injury on that side of the continuum over here when they're not weight bearing. So how do we determine where we are with somebody? We can use the algorithm that I've shared before. You know, first thing we do is make sure that the individual doesn't have any contraindications. The contraindications I've got mostly listed here. These are not all of them, but those are most of them. Most of the time we're looking for risk of deep vein thrombosis and risk to the circulatory system. If they have some sort of contraindication, then we want to consult with the patient's physician or surgeon before implementing. And maybe they say BFR is not appropriate, so then we wouldn't utilize it. If it is approved or if they don't have any contraindications, we have to ask ourselves, is the patient mobile? If they were not mobile, meaning they have a brace on or a cast, they can't weight bear, they're bedridden. Any of those things, they have a cast on the upper extremity too. This can apply to the upper extremity. We would say, no, that joint or that tissue is not mobile. So we would say no. We would start the cellular swelling protocol sequence. I usually will start with 100% limb occlusion pressure if they can tolerate it for 5 minutes on, 3 minutes of free flow for 5 rounds. Then I will add some E-stim, and this is where we're talking about right now is this neuromuscular electrical muscle stimulator. What kind of unit are we going to use? And that's what I really want to talk about today. So I wanted to put this algorithm up so you could see where are we along the continuum, and we're in this cellular swelling protocol, and we're going to use it here. Now we will use E-stim in the performance protocol from a recovery standpoint when we try to stimulate growth hormone without stressing tissue. So we could use it there too. We're going to use the same unit, whether it's here or it's here. And that's why I really like this unit. So hopefully everybody knows where we are. And by the way, if you have any questions, just put them in that comment section so that I can comment when we're all done, because I don't see the comments as I have this up. All right, so here's where we are. What type of E-stim unit are we going to use? So I'm gonna back out of this. And I'm going to stop sharing my screen for a second. Okay, so if any questions, just kind of throw that right into the comment section. So I'm going to show you the unit that I'm using right now. It's called the PowerDot. And the PowerDot is it's cool. It has these 2 different sets of leads, and so this is one lead, and then I also have another lead. Jeez. Okay, so here's another lead. So I have these 2, and these can go onto the limbs, and I control this with my iPad or my cell phone, and I'll show you how that works. So let me put on a cuff so you can see. So let's say I had a cast on my arm. I would put the cuff on. And then what I would do is if I want to try to prevent atrophy from in my upper arm, I would take one of these and I would put it above the cuff, and then I would take these 2 guys. This one's going to the left. And I'll usually get it there. And I'll take it there too. So you can see how I'll utilize that. Now I could take the second one and I could put it on my tricep above and below. If I felt like, if let's say the cast was too high, then I could scoot these below as well. If it's more of a wrist injury. So I can manipulate where I want these electrodes based on where the cast or the brace is. Why don't I'm going to scoot these up more onto my bicep. Okay. So you can see that I just turned it on, then it connects very simply. Now I'm going to go onto my extensor group. So I'm going to place that on there. Okay, there we go. So this is how I could set up for my upper extremity. So I'm going to be stimulating the muscles here, and I'm going to be stimulating the muscles here. And it'll change depending on where the cast is in the brace. In my leg, I typically am going to have the cuffs on here. I'll put it above. I'll stimulate here and here, vastus medialis and vastus lateralis, and I'll hit the calf as well. So I'm hitting the whole leg using these two different leads. All right, so let's talk about how to do this. These are going to be controlled through your iPad or you can also use your cell phone. And they also say you can use iPad Touch or iPod Touch. I don't have any iPod Touches, so I'm not using that. So I'm going to share my screen again. I'm going to go to the settings so you guys can see how this works. Share my screen. And to be honest, if I can pull this off, this will be amazing. All right, so I'm going to go here, and I'm going to go here. Okay, so I'm going to go on my iPad now. Hopefully you guys can see this. I'm going to expand the screen. Now you can see here from the beginning, I'm going to choose where I want these exercises to be. So I'm going to go into performance settings. There's a bunch of different settings. Now what I'm hoping, and I've talked to the folks at PowerDot, is that they're going to put in They're going to put in a clinical version for pain control, which will be more of a TENS unit type setting. And then also, but you can also do Russian stim on this. You can do a variety of different settings. I'm going to show you how to customize the settings, but they have a bunch of pre-ones kind of non-medically, but then they're going to put a clinical one in for us, I hope, by the end of this year, beginning of next year, when their new release comes out, which will have a BFR specific setting. So it'll be easy. You won't even have to go in and do these settings. So what I'm going to do is go to performance, and I'm going to go to muscle endurance. And then I'm going to go into, it doesn't really matter which area you choose. I'm just going to choose lower back because I know the settings are high enough to do that. I'm going to go into manual settings. Okay, and then I'm going to say, okay, hey, I'm going to turn on manual settings. And I'm going to say, okay, for contraction, how long do I want that contraction to hold? And I want that contraction to hold 3 times longer than what my rest ratio is. I kind of have found that when I'm having people do isometrics, I have them do 5-second holds because 10 seconds seems a little bit too long, and then I've got to give them a 20-second break, and they get kind of distracted and bored, and they lose focus. So I've been doing contraction. Typically, we'll kind of bring this up, and we'll do this. Let's bring this up to, let's bring the contraction up to 10 seconds. So if the 10 seconds, what we're going to do then is we're going to increase the frequency to about 20 hertz. You can see how customizable this is. This is where I really like it. So my contraction to rest ratio is supposed to be around 3:1. So if I went, let's say I go 9 seconds on this, my rest should be 3 seconds. So we'll do that. And it doesn't matter what the frequency is during the rest period. Ramp up time. So ramp up is, do you immediately jump into that contraction? I find that that's a little bit aggressive, and patients find that it's uncomfortable. So the ramp up I have found to work the best is 2 seconds, and then ramp down is 2 seconds. Pulse length, according to the literature, should be around 400 microseconds. All right, and then total contractions, don't worry. You're just gonna let it run. So you can turn this up all the way so you don't have to worry about it. And then I'm going to save. And now that's my setting, and this would save all the time. So if you always were using this, you could always go to this, which is typically what I do, but I wanted to show how that all works. So now what I'm going to do is I'm going to say I need to recharge. Of course, this is always, which one is it? Do I have to recharge? This is like Murphy's Law, isn't it? Right when I go to do this, it needs to recharge. Let me see if I can charge it just for a second. It's okay, I'll keep going. You'll see what I'll do. So now what I'm going to do is, oh, I recharged the wrong one. I am on a roll. Okay. All right, we're gonna turn that guy off. And then I need to just, this seems really complicated, but it's not. I'm just running into Murphy's Law here. So again, bicep here. What I'm going to call this is let's get started. We're just going to use 1. Now what you can do is you can go into it and you can separate, which is normally what I do. So down here, you can link the channels. If I had 2 plugged in, it would ask if I wanted to link the both my upper arm and my lower arm, or if I wanted to separate them. Because they're 2 different areas, two different size body parts, I typically unlink them. Linking the channels means that I can have this one and this one to be separate. So sometimes one of them will be kind of bitey, then what I can do is I can separate them, turn one down or turn the other, or they can be linked. I've also found that if it does become bitey, just use a little bit of ultrasound gel underneath, and that really helps. I'm going to take this off to avoid confusion. All right, so I'm all set up, ready to go. And what I can do now is I'm going to skip. There's usually some sort of introduction or a startup, warm-up. So I'm going to skip that. Are you sure you want to skip? And the answer is yes. And now I'm going to adjust the intensities. I'm going to link the channels because I'm out here. So I'm just going to increase this. Kind of to my tolerance. Now I'm getting the muscle to move. Okay. So that's kind of how you set this up, and you can set it up really fast, really easy. You can have them set the way that you want them. You can use them on different body parts. Technically, I guess you could have 2 duos, which would mean you'd have 4 total. You could be using both left and right. I just have the one set, and I use those on the injured limb. So now I'm going to stop sharing so you guys can see this. Okay, so I've got this guy on. Right now I can feel it, it's contracting. I'm getting contraction through here. Now, once I have the E-stim on, then what I would do is inflate. I wouldn't inflate first and then do the E-stim because that extra compression may alter the electrical signaling. So have the electrical signaling on, and while it's firing, then inflate. And I'd be inflating to somewhere between, I usually get that thing up to about 80 to 100%, even in the upper extremity of limb occlusion pressure. So I'm really stimulating that pretty high to their tolerance, usually slightly below 100. And so this will just go on, and and the protocol for the cellular swelling is 5 minutes on, and then 3-minute free flow. During that 3-minute free flow, I usually keep the E-stim churning, or you could pause it very easily. There's a little pause button. You could just pause it and then work on soft tissue or do something else, depending on how much time you have. You could work on other parts of the body and then reinflate, and you're gonna do that for 5 rounds. Patients take these home from me, and they can rent them. And so that way they can do it twice a day, because really they need to be doing it twice a day ideally if they really want to prevent atrophy from disuse. Now, the other time that we'll use the E-stim is with contraction as well. So I could do an isometric contraction with the E-stim and the BFR cuff on at the same time. These are all ways of increasing resistance to try to reduce the amount of atrophy. We need some contractile forces going through the tissue to stimulate growth hormone, ideally. And that really helps with your lactate production and also with atrophy. Okay, so that's my quick and dirty on the E-stim units that I am using. I'm going to turn this thing off. Take off my cuffs. Let's see, I think I have a bunch of these E-stim units that I've tried. I mean, I've got they're just all over here in my desk. I've tried all these stim units. It's crazy. I've got boxes and boxes of them. And I haven't been able to find one that I can really set the way I like, and that's why I'm really digging these. Hopefully they will make us a new setting, so we don't even have to mess with the settings ourselves. But in the meantime, it's not that bad once you get used to it. Any questions? Questions about the NEMS unit that I like right now, and how to do the settings and when we would use it. That's probably the most important. All right, well, I got patient waiting, so that has been 26 minutes. I'm out. See you next week. If you have any questions at all, ed@edlacara.com, please leave me some comments on what you'd like me to talk about, because I'm always trying to search for content. So otherwise, have a great week. Thank you so much.